Hello, my name is Jane Englebright. I'm the Chief Nursing Officer and Patient Safety Officer for HCA. Welcome to this module on realizing the promise of improved patient safety through health information technology. Our objectives today are to describe strategies for evaluating both the intended and the unintended consequences of health information technology implementation from a patient safety perspective, and to apply failure mode analysis techniques to assessing health information technology applications and the implementation strategies that we use. As with everything patient safety, we'll start with the IOM report. In particular, the second IOM report, Crossing the Quality Chasm, a New Health System for the 21st Century. This report is really what is behind the great efforts that are happening in the United States today to implement health information technology. This report clearly delineates how knowledge-driven care, coupled with technology, clinical information systems, and various applications, leads to improved outcomes for our patients. So many of our hospitals and health systems and various care settings have been moving rapidly to adopt different technologies with the goal of improving outcomes for patients. The business case for HIT often claims patient safety benefits as one of the main drivers for adopting health information technology. Part of our role as patient safety specialists is to participate in these HIT decisions and have responsibility for the specific elements that are related to patient safety. So moving on to slide 4, the health information technology decisions usually have a patient safety component to them. And as patient safety leaders, it is our responsibility to do 4 things. To establish meaningful goals for patient safety improvement within the HIT implementation project. To define a measurement strategy for each phase of HID adoption process and understand the impact that technology will have on patient safety. To assure that the organization realizes sustained patient safety benefits from the HIT investment, and to protect the patient and the organization from unintended consequences of HIT implementation. So starting with the first one, establishing meaningful goals for patient safety improvement from HIT implementation, the main question we ask ourselves is how will you know if the health information technology has actually improved patient safety? There are again 4 things to begin to look at. One is to examine external benchmarks and use that to gauge the opportunity that exists. You can look to the literature, to published research studies, to case reports, or even site visits of other facilities who have gone down the path you're about to go down. What did they experience? What type of safety improvements did they achieve through their HIT implementation? The second step is to begin to collect your own internal baseline data. Do you have these problems present in your institutions at this time? And the third is really to seek understanding rather than validation as you begin to define your metrics. Not so much looking to prove whether you're right or wrong or prove that in fact the HIT is making patient safety better, but rather to identify what is changing with the adoption of this technology and to look for the ripple effects of that change throughout your processes and your outcomes. And finally, to set clear and measurable patient safety outcome goals, because this is really how you will demonstrate the return on investment for your facility. I'm going to use one case example as we go through this from my own experience, and that is deploying the EMR and barcoding technology. I work at HCA, which is a 170 facility hospital system, and we deployed the barcode-enabled medication administration system to all of our hospitals between 2002 and 2005. We followed that implementation with periods of optimization in 2006 and then expanded to outpatient areas in 2007. The examples that I use throughout this presentation will be drawn from those experiences. So let me begin with a measurement strategy. In this example, our goal was to understand the impact of the technology deployment on medication safety. We had 4 expected outcomes that we were watching for as we deployed this. The first was that we would have fewer medication administration errors. And to measure that, we looked to 4 sources of data: incident reports about medication errors, the actual avoided errors reports that came out of the technology, a report of our malpractice claims related to medications, and finally the stories that we collected from staff along the way. Our second expected outcome was that we would have more complete documentation, and we measured that through chart audits both before and after deploying the technology. Our third outcome was that we would have improved accuracy of billing, and once again we measured that through chart audit before and after deployment. And that our final outcome was that we expected the staff to perceive improved safety, and we measured that through a survey of our nurses and respiratory therapists who were the actual end users of the technology. And then we began to look for would there be any unintended consequences from this technology. And we looked for that in two ways. One was from a survey of pharmacy staff on the perceptions of workload changes, and looking again for what would be the ripple effects of the changes to that workflow on other aspects of safety, and then through journaling and keeping anecdotal records as we went through. So in terms, as I move on to the next slide, still within this case example, as we go to gauge the opportunity for patient safety improvement, we look to external benchmarks and our own internal metrics. We went to one of the classic studies from Bates and colleagues from 1995 that told us 2% of hospital admissions experience a medication error. And of those medication errors, 34% happened during the administration process. So the technology we were deploying was specifically geared toward that administration process. So using those percentages from that study and the 2001 admissions, 1.5 million at HCA, we then derived an expected impact of eliminating 10,636 medication errors. We also went to our malpractice claims database and discovered we had 164 errors that resulted in claims that year, and looked at those also as a percentage of admissions. The low numbers there were a reason why at the very beginning risk management was not very interested in this project, because it looked to be such a low number in their total claims experience. We'll come back to those numbers later as we go through this example. But let me pull up again to talk about the second area, which is defining a measurement strategy for each phase of HIT adoption to understand the impact of the technology on patient safety. In this area, we want to define metrics for each phase of implementation, as well as have a plan for collecting anecdotal information and to watch for emerging workarounds. We can't really leap directly to outcomes measurements. We need to start with milestones and then progress to process measures and finally to the outcomes that we're driving for. This next slide gives you a picture of the steps involved in the phases of HIT deployment. We begin with the implementation period, which is the time in which the technology is really getting laid down when there's very little usage, and we're really looking at project milestones. Did we get the safety features built? Did we get them tested? Are they working as we think they will work? Then we move into the early use, when we are really focused on utilization statistics. Is the technology being used to the extent that we expect it to be used? If not, then our first improvement actions are to improve utilization, to figure out what are the barriers that are keeping people from using the technology and to work our way through resolving those barriers one by one. The third phase involves stabilization. This is where we're beginning to pull back on the support we've been giving, and it's becoming a part of how we do our daily work. And our question here is compliance. Is the technology being used as it was designed to be used? And if not, we need to really look at the workarounds that are emerging and work to improve compliance with the process as designed. The fourth phase is adoption. This is where we can finally begin to look at those outcomes and see, are we in fact averting errors? Is it having the effect we thought it would have? And if not, we need to go back and review a lot of our design decisions and our workflow decisions. And finally, at the completion of the project, we need to be able to analyze the effect that we're having and really calculate a return on our investment. Are we in fact getting the safety outcomes that we expected? And has this really become the way in which we do things in our organization? Now, the length of each of these phases varies from days to even years based on the technology and your implementation approach. Let me return to my example, because this is one where it is literally taking us years. So in this case example of EMR and barcoding, we began in that early process to look at our utilization statistics, and that is a real focus on how many doses are being given and are they being given with the scanning technology. And as you can see in this example, we only had about 20% of the doses that were being given using the technology. So we began looking at why was it not being used. What were the issues from a people point of view? Was it training? Was it lack of access to equipment? Was it lack of knowledge on how to use the equipment? Was it involving the processes of giving medication in the various care areas? Or was it the technology itself, such as areas where the wireless wasn't working, dead zones, or scanners that were losing their programming? And we worked our way through each of these issues in each hospital on each unit. And we gradually got to the next phase, which was stabilization, where we could start looking at compliance reports. These are reports that told us, in this example, when the medication was administered, the time that was entered the computer, the time that the administration was actually filed in the computer, and the time that the medication was scheduled as due to be given. When we saw greater than 30-minute discrepancy between the time the medicine was charted as given and when that entry was filed in the computer, we knew we had something that wasn't happening in real time at the bedside, that they were in fact not scanning at the time they administered the medication. So we had compliance issues that required us to do follow-up, observation, and discussions with individual practitioners on the importance of this safety technology. In the next phase, we moved to looking at averted errors. So as we began to get really good adoption of the technology, we knew it was being used in a compliant manner, then we could have faith that our averted errors were truly averted errors. In this case, with this technology, we looked at the total doses administered, the number of warnings that the system generated around those doses, and then the number of times the medication was not given after a warning fired, and we called those our averted errors. Note that there is quite a discrepancy between the number of averted errors we saw in 2005 and the 10,000 or so averted errors we expected when we set out our plan in 2002. Finally, we began to calculate the return on investment from our patient safety technology. We looked at our avoided errors and our avoided malpractice claims related to medications. And surprisingly, we saw great improvement in both of those areas. So many more averted medication errors than expected, and a 30% reduction in the number of claims related to medication errors, and a 50% reduction in the actual cost of claims that we paid. So continuing on with that example, the unintended consequences are something we were also looking for, as well as many soft benefits that couldn't be quantified or counted in the same way that we had done with the averted errors. We looked for an impact on patients, and we wanted to see reduced pain, suffering, and harm from a patient point of view, and the patient's improved confidence in care. We collected this anecdotally through stories and testimonials from our staff. From a staff engagement point of view, we wanted to see a perception of safety, and we did see that in 100% of the surveys that were returned from our nursing, pharmacy, and respiratory staff. And we also saw it as an indication that many of our hospitals began using the fact that they had this technology in their recruitment ads for nursing schools. And then the third area was looking at organizational achievement. HCA received 2 awards from the Institute for Safe Medication Practice, the Cheers Award, and from the Unsummit organization, the Waypaver Award. We also got recognition from some local QIOs, and many of our hospitals had coverage from their local media. And the next slide here is a case example from the EMR and barcoding deployment. It's a journal entry from a neonatal intensive care unit nurse who was alerted by the technology that she was about to administer the wrong IV fluid to the wrong twin in the neonatal ICU. So her scan note to pharmacy says, "New EMR just prevented IV error. 2 strengths of D5W with bicarb were in the fridge. and I tried to hang the wrong bag. I never would have caught this by myself until it was too late. I'm a believer now. This type of testimonial was used over and over again as we worked on growing adoption, and in almost every deployment we found one of these stories within the first 24 hours of being live on the technology. The next slide gives you an example of some workarounds. And workarounds get something of a bad name in patient safety circles, but they're actually just signals that process and technology are not aligned, and they are a very rich source of improvement data. So here are 3 examples of some workarounds that we discovered. The first was that our focus on scanning percentages in that initial utilization phase drove the nurses to save medication labels and stickers to scan. This obscured problems with our printers. Once we realized it was happening, we put all of our label printers on a schedule for changing out the ink cartridges and improving the quality of the barcode, eliminating the need to have to save extra stickers to get scanned, and the workaround quickly went away. Another workaround that we identified was low scanning percentages during the flu season. And what we found going to the units is that nurses were not taking the barcode scanners into isolation rooms because they wanted to avoid having to clean the equipment after its use. So what we did here was we attached cleaning wipes to each of the medication carts so that they could easily be wiped down without taking time away from patient care. And again, this workaround decreased significantly after we did that. And then the final example is an increase in overrides in the automated dispensing cabinets began to occur, and this identified some delays in pharmacy processing after-hours medication orders. So working with the pharmacy to improve their turnaround time on orders greatly increased our scanning percentages, resulting in more patient safety on a couple of different fronts. So the third area of responsibility for the patient safety leader in health information technology adoption is to assure that the organization realizes sustained patient safety benefits from the investment that they've made. The quote here from Poon et al. Talks about the development of healthcare information technology should be thought of not as a single event in time, but rather as an iterative process that requires modifications and improvements. Regardless of what your employment or deployment plan looks like, it will take you much longer than that to have technology really become a part of the fabric of your organization. Again, going back to our EMR and barcoding example, we began in 2002, and it is now 10 years later, and I can tell you we are not done. You see the timeline here that we've been on, starting with a pilot in 2002, through our initial release, the rollout to 154 sites completed by the end of 2005, optimization activities where we went back and revisited practices and technology upgrades, movement of the technology into all areas, including outpatient and procedural areas, and now getting ready next year to go back and revisit our basics to make sure that we are in compliance with meaningful use stage 2 requirements as those get defined. One of the things that happens with HIT deployments is it makes previously invisible processes very transparent, and it provides a lot of data for monitoring and continuous improvement. These are just a couple of examples of the types of reports that we get out of our EMR and barcoding technology. At the very beginning, our CNOs were very overwhelmed with the amount of data that was coming out of this. This was a process that most assumed was working well given the relatively few reports, incident reports, malpractice claims that we had coming in this area. The assumption was all is well. The reports began to show that there was in fact lots of opportunity for improvement. Currently, these are the types of control charts that we use to monitor our EMR and barcoding utilization and error management across all of our hospitals. Through this type of trended reporting, we can see the impact of technology changes in our optimization efforts, and we can be on the continuous lookout for degradation in performance or drop-off in utilization of the system. These are the reports that we share with our board on a quarterly basis. So our fourth area of responsibility is to protect the patient and the organization from unintended consequences of HIT implementation. Now, there are several types of unintended consequences that can occur. Some of these are related to the human and technology interface. New kinds of errors, the famous slip of the cursor, bypassing safety features or warnings that the system generates. Overdependence on the technology, thinking that I don't have to pay attention or don't have to read labels myself because I'm using a scanner. And a loss of focus on the non-technology elements of care, actually really looking and talking with our patients. And then issues related to the organizational or system change. We are changing how communication flows throughout the organization. We're changing how our work processes happen. We are encountering a lot of stress, anxiety, and other negative emotions, and really some unexpected changes in the power structure as data become readily available to all. So the next slide gives you those phases of HID deployment and talking about the unintended consequences that we can encounter in every one of those phases. As we get ready for implementation, we can see anxieties go up and we can see errors that begin to be integrated into the system through inadequate design, training, or support efforts. During the early use, we have a lot of interruption in workflow processes and team communication, and really can lose situational awareness. We can have seen caregivers get so focused on the technology, they forget to look at the patient in the bed and can even miss patients in distress. During the stabilization time, we can see persistence of previous practices right alongside the new. So the failure to give up the paper-based process or the non-technology-based process leads to duplication of data and fragmentation of the patient record and a lack of reliance on either one of the systems, either the old or the new, because neither is complete. During the adoption phase is when most of the workarounds begin to surface. That we have now learned the technology well enough to know its limitations and to know the places in which it is not supportive of the workflow, and so we develop our workarounds. And finally, in the completion stage, when we think we're done, we will encounter special patient populations or special patient care areas that really do have unique and different needs that we have failed to account for in our larger project plan. So let me give you a couple of examples again from the EMR and barcoding deployment and make the point that not all unintended consequences are problems. In fact, some of them can be quite positive. In this example, we had one negative consequence in our early deployment, which was the medication dose field accepted scanner input, allowing the nurse to inadvertently have the cursor on the dose field scan the medication identification number, the NDC, which is an 11 to 12 digit numeric entry that would go into that field of doses and would charge the patient for and in fact record that the patient had had a couple of million milligrams of whatever it is we were about to give. This caused some great anxiety in our billing office and actually locked up the computer system in a couple of instances. Luckily, easily and quickly fixed. One of the positive consequences is once we got going with barcode verification, it eliminated the need for second nurse verification on some of our high alert medications because the machine was much more effective at reading the names, numbers, and doses on those medications than a second pair of human eyes were. But unintended consequences have really received a lot of attention. In 2008, the Joint Commission issued a Sentinel Event Alert, number 42, on this issue, and they talked about safely implementing health information technology and converging technologies, and they issued some pretty strong language that users must be mindful of the safety risks and preventable adverse events that these implementations can create or perpetuate. Technology-related adverse events can be associated with all components of a comprehensive technology system and may involve errors of either commission or omission. This alert caught a lot of attention, and I think it resonated with many of us who have been working in this field for some time as right on target and really capturing the essence of the problems that we're trying to solve, while at the same time not creating new problems. Health information technology related errors almost always jeopardize patient outcomes and have a high potential for harm because they are latent errors that occur at the blunt end of healthcare and can potentially affect large numbers of patients. We've talked for a long time about the sharp end of errors, that is, the direct caregiver working with the individual patient. The direct caregiver can make errors, and errors at the sharp end are particularly problematic because they go directly to the patient without a lot of mitigating factors in between. But the good thing about these errors at the sharp end is they generally happen one at a time, one caregiver with one patient. Policies, procedures, and technology are considered to be the blunt end, and this is where systematic error can very quickly affect a lot of patients. So a ordering rule that is entered incorrectly and used for 24 hours or 48 hours will affect every single patient who had that order placed within that period of time, potentially having a very large impact. In 2007, a new term was introduced called e-iatrogenesis. This term is really defined as patient harm caused at least in part by the application of health information technology. Watching for episodes of e-iatrogenesis is a big part of implementing a health information technology. So one strategy for identifying and prioritizing these technology process gaps that have the potential to harm patients is to use failure modes and effects analysis. I think we've covered this in some earlier modules within this series, but just as a review, failure modes and effective analysis is a procedure for analysis of potential failure modes within a system for classification by the severity and likelihood of failures. FMEA, as we usually call it, is effective in identifying safety concerns with HIT products and with implementation plans, and it can be performed either pre-implementation or post-implementation. Here's an example of an FMEA that was done on an e-prescribing technology that we were beginning to design. This exercise was done with an interdisciplinary team of both users and computer experts. And if you read through the different steps of the process of using the technology that they identified, and then the failure mode associated with that particular step, you'll see that some of them are very caregiver specific and some of them are really related to the technology and how it works. Then we talk about what's the potential effect of that, and we rate it as a team on the severity of that effect, the occurrence of that effect, how often would it happen, and the detectability, how easy would it be for us to find this problem if it were to recur. Then we multiply those three columns together, severity, occurrence, and detection, and we come up with a score, which you see reflected here in the RPN column. And then we go through and rank those scores. So you can see the first one, which was sort of the global problem of handoffs and communication gaps, with the effect of having an incorrect drug and or no mapping of a drug, had an overall score of 640 and therefore received a rank of 2. The last example on here, number 4, the pharmacy technician manual correction of recycled NDCs in the technology, had a score of 540 and a rank of 4. The ones in between did not get ranked because they were so far below others. Obviously, this is a multi-page report that I've just given you a snapshot of. So the FMEA provides a prioritized list of safety concerns that give direction and prioritization to a variety of things. Things such as user requests for software or setup changes, training needs, workflow redesign needs, and go-live support needs. It also gives you a comparative list of safety concerns that allow you to do a meaningful trade-off analysis to address user concerns and to quantify relative benefits and risks of differing approaches to improving the software or changing your approach. This is a good way of inserting some sort of objectivity into what can sometimes be a very emotional and passionate discussion among your users. So in summary, the Joint Commission Sentinel Event Alert gives us some great words of wisdom. It says the overall safety and effectiveness of technology in healthcare ultimately depends on its human users. Any form of technology may adversely affect the quality and safety of care, and not only must the technology or device be designed to be safe, it must also be operated safely within a safe workflow process. We must be willing to change our clinical processes if we're going to realize the full benefit of health information technology and mitigate new risks associated with that technology. The last line of defense in patient safety is an active, empowered, and questioning patient, and a caring, listening, and thoughtful caregiver who approach health information technology as a useful tool, but not the be-all, end-all answer. That lies in our relationship with each other. Thank you all very much for your participation in this course. That will conclude this lecture.